Quiet down. Here we go. Coming to air in 5, 4, 3.
Everyone, happy International Nurses Day and welcome to Caring Essentials Virtual Summit Essence of Caring. My name is Nicole Duran and I'm the Operations Manager for Caring Essentials and Executive Assistant to Mary Coughlin. We are so excited to begin today's program and would like to go over a few housekeeping items before we start. Everyone is automatically muted to minimize background noise and distractions. If you would like to ask us a question or share an insight, please use the raise your hand feature, which you can find when you click participants. Select your name and then you should find the option to raise your hand. You may also share your questions in the chat box as well. We expect your full participation during the session, so please minimize other windows, put your Zoom window on full screen and select the gallery view. We will try to be attentive to your questions and ask for your patience. Our faculty for today's summit includes Christy Fuller. She is an occupational therapist and certified neonatal therapist from Iowa. She is passionate about sharing a preventative model to support feeding success and consults in newborn intensive care units across the country. Tara DeWolf is a physical therapist and developmental specialist from the Midwest. She is a dynamic leader in her field, specializing in trauma-informed approach to newborn developmental care and early intervention. Shannon Frey is the supervisor of speech pathology at Omaha Children's Hospital. She has a transformative way of integrating a trauma-informed approach throughout the developmental continuum. You should have all received via email a session worksheet and activity worksheet. Your certificate of attendance will be emailed to you within 24 hours. Now, I would like to introduce the host and facilitator of today's virtual summit, Mary Coughlin. Mary is a former NNP and is the founder and president of Caring Essentials Collaborative. Mary is the internationally recognized expert in trauma-informed care in the NICU, has authored several books, chapters, and papers on the topic. Please welcome Mary Coughlin.
Thank you so very much, Nikki, and I'm wicked excited to be here, and I'm over the moon that we've had so many folks interested in this topic and who have registered. I do want to let the folks know that have registered and may not be able to join us I don't know why that was happening, that we're going to host the recording on we have a member site, and we'll give you guys all access to that in addition to the slide deck and that sort of thing. So don't fret. You know, I really, myself and the faculty really want you to be here and really experience the content and join in, okay? We're gonna have some questions and really try and get you guys to engage in this subject. So I'm just gonna share my screen now with the slide deck. The Essence of Caring. This is our very first virtual summit, which is even more wicked exciting. And I feel really privileged to be able to share this content on such a very special day for our nursing colleagues who are here on the call, as it is the 200th anniversary of the birthday of Florence Nightingale. Woo woo. She is one of my heroes, all-time heroes, as well as many of her successors in nurse theory. So, and I'm really psyched that the faculty panel was able to join us. And what we're going to do is I'm going to be presenting, you know, kind of like some content, and it really hinges on the history of nursing and caring in nursing. But caring isn't just about nursing, right? I mean, caring transcends all disciplines. And so I'm looking to our faculty to share what caring means to them within their clinical practice. And then we're going to open it up to you guys and really, you know, get juicy, right? Get a really good dialogue going and talk about not only what caring means to us, but what are some of the challenges that we face in operationalizing authentic caring in our clinical practice. Let's see if I can do this right. Okay, so my learning objectives include describing what caring science is, talk about the physiologic, psychologic, and existential implications of transpersonal caring, and I'll give you a little bit of background in a few slides from now about what that means, and then list 3 benefits of caring science for families in crisis. And although my background is pretty grounded in the NICU, I don't want to make you think that it's only the NICU, right? This concept transcends all patient populations. You know, hospitalized infants are my specialty, but this goes across the entire continuum for vulnerable patients across the world and in all clinical settings. So let's kick it off with a tip of the hat to our foundress, Florence Nightingale. Florence is the founder, really, of professional nursing. She was born in 1820 in Florence, Italy, and that's how she got her name. Her parents thought that was really cute. Her family is from the UK. And this was just a really interesting timeline, I thought, to share with you guys, because I'm a wicked nerd about Florence Nightingale. And Florence Nightingale really was the first nurse theorist, although she wasn't called a nurse theorist in her day. But theory really is that backdrop of knowledge, intuition, information that helps us form the foundation for our discipline. So medicine has a theoretical platform or foundation. Allied health, they have theoretical foundations. Psychology, all the different sciences. And she was really the first one to start to delineate what exactly constitutes nursing practice. And it was her initial work. She's written a bazillion papers, but her initial book entitled Notes on Nursing that really was not only pioneering and relevant in her day, but it has stood the test of time. And I'm going to share with you on the next slide how what she's identified as those aspects of nursing still ring true today. What Florence described were, her theory really is grounded on this idea of the environment. And on first pass, at least for me, when I think of the environment, I generally think of the physical space, right? I think about, the smells, the lights, the sounds, the space, and all that kind of stuff. But Florence was a very wise woman and very intuitive. And she said, yes, of course, the external environment plays a big role in how we nurse individuals back to health. But it's not just the external environment, which you see here in column 2. The internal environment was really critical for, in order to identify who were those folks that we should be inviting into the profession, right? And so she talks about this internal environment really engaging body, mind, and spirit wholeness, fostering healing relationships and partnerships, promoting self-care and health promoting and health sustaining behaviors in self, because, and we'll get into this later in that discussion, you can't give what you don't have. And the work of nursing, the work of allied health, the work of frontline clinicians is very draining. It's very taxing. It takes a lot from us. And so if we're not mindful of filling up our cup, and this is wisdom from the 1800s, right? The 1860s, where Florence was recognizing this is a key aspect of the quality of the caregiving that patients receive hinges on the wholeness of the caregiver. And that the internal environment, it's also about engaging with and is affected by elements of the external environment. So, for me, I go right to the NICU. I want you to go right to your clinical setting, right? And think about the busyness of it, the sights and the sounds, the smells, the people in it, so it's not just the furniture and the, those accoutrements, but it's the individuals too that are part of that external environment that affect us. You may come on shift feeling on top of the world, refreshed, and by the end of your 12-hour day or 8-hour day, whatever you're working, I'll bet you're not feeling as perky as you were at the beginning, and it's not just because 12 hours have passed, although that certainly is a contributing factor, but it's all the stuff that occurred, right? The folks that you had to interact with, maybe some of the less than optimal encounters, superimposed by the alarms, the lighting, and the rush of the environment. So this is really what Florence described as the essence of nursing. And she goes on in her book, Notes on Nursing, which I recommend to absolutely everybody, to talk about these small things. They may appear small, right? In the external environment, you have to remember in the 1800s, what was really available to nursing, what was available to medicine. And in fact, it was Florence that identified the relevance of sanitation in really helping people recover. A lot of the people that, the soldiers that passed away, they passed away from secondary infections because there wasn't good sanitation. So, it kind of all builds from very humble beginnings on our understanding of the core elements of healing. And as I say that word healing, the message from Florence Nightingale is not about how technically proficient we are and how wicked smart we are about all the different medications and technological equipment that we have. It's really about our capacity to put the patient in the best position for nature to work on them, right? Our job is to manage the human experience with disease. And by making sure that they're comfortable in their bed, right? That there's cleanliness around the space, that they're getting optimal and appropriate nutrition, that there's good ventilation, all these types of things, they reduce the stress of the patient, and by doing that, they put the patient's body in the best place for it to then heal and recover from whatever illness that they're facing. Now, I just want you to pay attention now to this timeline because I was pretty struck by it. So this is Nightingale, 1860s, first nurse theorist. We don't see another nurse theorist on the scene until 1950s. That's a big dearth of time, right? I mean, and in the 1950s, that was when nursing scholars really came together and realized that there was a paucity of substance, a paucity of theoretical knowledge that really could underpin nursing. My nursing colleagues on the line will probably maybe cringe a little bit, but historically nursing has been referred to as the handmaiden of medicine, that basically our role was just to buzz around and do whatever the physician told us to do. And in some ways, some of that mentality persists today. But in response to that, the early nurse scholars recognized that there was a need to really delineate what is nursing practice? What are the theoretical underpinnings? And Peplau, Hildegard Peplau was one of the first nurse theorists to kind of kick off this renaissance, if you will, of nursing theorists and nursing theory. And a lot of the direction that these early nurse theorists went off on really wasn't about caring. Because during that time in the 1950s, and I want you to, I mean, if you're really, really young, this might seem so wicked foreign to you. But in the 1950s, it was a very, male and female had separate roles. It was very class driven. It was very masculine driven. I hope I'm explaining this okay, but it was very, it was a tough place for a woman to kind of stake a claim in employment and really carve out their role in a meaningful, measurable, respected way. And nursing struggled with this for decades, and often in many parts of the world, they continue to struggle with an identity that is recognized based on the scientific foundations of our profession. And so at the very beginning of nursing history, past Florence, but before kind of contemporary nursing, a lot of nurses didn't really want to connect with the idea of caring. They felt that it was too woo-woo. It was too fluffy. And at the time, it was really decided that it's really hard to quantify what is caring. You know, it's kind of an aesthetic, it's an art. And so a lot of nurses said that is not what nursing is based on. Nursing is based on our ability to assess and identify problems and manage those problems and take care of needs for patients. And a lot of our allied health colleagues really kind of were born out of this recognition of needs of different patient populations. You know, you look at physical therapy, you know, really born out of the polio epidemic, and occupational therapy, speech language therapy, really that rehabilitation resource for patients that were not able to care for themselves. And those early nursing theorists were also looking at, you know, things that we could fix, things that we could respond to, and really didn't look at the art and science of nursing from a whole person perspective. And this went on for quite some time. So Peplau, she kicked off her theory. It was like the early 1950s. Since then, you know, we really kind of got into some momentum, had a few theorists, you know, start to put forth their ideas around nursing, the domains of nursing practice, if you will, in these different meta paradigms is what they call them, where it's like about the nurse, it's about the patient, it's about the environment, and then it's about the tasks that you have to do. And so the history behind nursing being so task driven is really embedded in the foundations of nursing. So, and that's really hard to break. And I'm sure a lot of the nurses on here and the therapists can really kind of understand, like you see nurses and we're like checkbox addicts. This is how we measure and quantify the work that we do, because it's kind of been ingrained in us that the fluffy stuff, the ooey gooey, lovey-dovey stuff, well, we can't measure that, and that doesn't give us any respectability. So we can do that, but that's not what's going to define us. And it really wasn't until the early 1970s that a very forward-thinking nurse theorist, Martha Rogers, came on the scene. And Martha Rogers was really, previous nurse theorists were starting to look at this idea of relationships and those dimensions of interactions that we have with other as maybe having some kind of a benefit to the patient's psychology, but nothing really tangible from a physiologic perspective. But Martha Rogers started looking at this idea of unitary or universalist approach to nursing, that we're all connected, you know, as a result of our shared humanity, that there's lots of similarities in how I experience separation from family, for example, or pain and suffering, as to how the patient may be experiencing that, and putting that in a wider context with nature and Mother Nature and all those other types of things. So she was really one of the first folks to kind of break away from that task-focused nursing theory framework. And then one of her contemporaries, Jean Watson, who I'm totally obsessed with as well, really went off, and she started exploring this idea of caring science. She got a lot of grief from her colleagues, you know, who were really saying, no, you can't focus that because we're going to lose our credibility. The mindset in the earlier days was that if you're caring and you're fluffy, then you can't be smart and technically proficient, right? There was this thought that they were mutually exclusive. But in fact, right, I mean, one of the greatest things that we can bring to our patients is our authenticity, is our caring, and is our compassion. Because what Jean really started to publish about, and she actually did research around this, that healthcare isn't all about curing. There's lots of patients that we're seeing in hospitals, even back in the 70s, right, that many of them, you know, weren't cured, but they were still able to transcend their illness. And she was intrigued by that concept and really started to dig in and try to understand, what is that aspect of nursing that is contributing to this healing experience in spite of curing. And she's gone on to do just an amazing amount of research that I'm going to share a little bit more about her theory in subsequent slides. But that's just a bit of a backdrop. And even today now, we've got an ongoing dearth of, an ongoing plethora of nurse researchers and nurse theorists who continue to try and build a solid foundation and understand the breadth of nursing practice is well beyond the skills, right? It's well beyond the check boxes. It's about, you know, being with and healing and serving folks that are vulnerable. And regardless of your clinical setting, I want you to just kind of take a moment and reflect, how does this sit with you? Does this, you know, does this make sense? Whether you're a nurse or whether you're a therapist or whether you're a physician, does the idea of caring make sense? Or is it something that, well, if I have the time, you know, I can be show a little caring, show a little compassion or kindness. Just think about that. Because as I mentioned, there's an excellent paper that I actually have added it to the member portal where I'm going to host the recording that I think you're going to really like. It's fudge, I forget the author now. Written in 2016, and she talks about this conundrum of caring, where because of these gender hierarchies and the biomedical framework and nursing's need to figure out how we fit into a very masculine environment. And when I say masculine, I'm not talking boy girl, I'm talking about like that energy, you know, that masculine energy. How does nursing as a very feminine profession balance themselves and find their identity in a world that is not very balanced from an energy perspective, and from a recognition that it's not all about the curing, that there's a lot of healing that happens in the hospital experience. Does anyone have a question about that? Am I explaining that okay? I'm gonna take your silence as a yes, but you please feel free to like throw some chats up there if a question, you know, comes to mind. So, and even within nursing, contemporary nursing, you know, when I was going through my nurse practitioner program and my years in critical care, I felt that, thanks guys, I felt that a lot of my colleagues really wanted to be known for how smart they were, how their critical thinking skills, you know, their astuteness in assessments, all very crucial and critical dimensions of nursing practice. But it's not an either or. And I think because the foundations of nursing was so focused on the tasks and not really ready to embrace those existential, those aesthetic dimensions of the art of nursing, that we really kind of went off on this tangent about trying to prove ourselves, trying to say that we're important and we need autonomy and all that kind of stuff. And so I think now this is like just such an exciting time. It's 2020. It's the year of the nurse and the midwife. This is the 200th anniversary of Florence Nightingale's birthday, and she set the tone. And she actually said in her later years that it would take another 150 years before nursing would advance to the place where it really was where she had envisioned nursing. And I think we're almost there. And I'm going to challenge my nursing colleagues to really stand in the power that we have on our scientific foundations and the existential foundations and the theoretical underpinnings of what it is that we bring to the patient experience. It's profoundly relevant. Who spends the most time with the patient in any given setting? It's you guys. There's power in that. There's beauty in that. There's reverence in that. And there's sacredness in that. What caring science is, according to Jean Watson, is that it's grounded in the ethics of belonging, which is greater than our being and expands beyond medical science. It acknowledges the relational life forces and the philosophical unitary field dimensions underlying all of humanity. I mean, this woman is an incredible visionary. Very, very spiritual, and she's kind of one of those theorists that she continues to grow and evolve, and the folks that adopt her model for practice continue on that trajectory and become grander and more holistic. And I think this was one of the inspirational dimensions of her theoretical work that underpins the idea of trauma-informed care. And more importantly, underpins our certification concept as well, where we're really looking at authentic healing presence, personal wholeness, courage, combined with knowledge as being critical to being able to serve the patients and families that we're privileged to serve during their hospital stay. On a grander scheme, she looks at the term that she uses is unitary caring science. She has a very recent publication that came out in 2018, her most recent. And I think this quote from the book really, at least for me, helps me grasp this very aesthetic concept. And she says that we learn from one another how to be human by identifying ourselves with others, finding their dilemmas in ourselves. What we all learn from it is self-knowledge. The self we learn about is every self, and this is universal. We learn to recognize ourselves in others, different aspects, right? It keeps alive our common humanity and avoids reducing self or other to the moral status of object. And I think, unfortunately, this idea of reducing self and other to objects is very commonplace in today's healthcare. And I know we use language to kind of be efficient and economize on time and stuff like that. But when we refer to our patients by their diagnosis, you know, the gallbladder in room 4, the 24-weeker, the diaphragmatic hernia. Now, certainly when you say that to me as a nurse, I get a visual in my head. Okay, the gallbladder, maybe not so much, but or the 24-weeker. You know, I get a picture of that, but is that picture really enough to help me fully serve that individual? You've just told me their gestational age, and then I can conjure up all of these complications and morbidities associated with being born at 24 weeks, but it doesn't tell me anything about the individual. And if I don't recognize the individual, what is the true quality of the care that I'm delivering that person? Do I really need to be a nurse to do that? And Jean Watson actually says in her book, you know, if nursing continues to define itself by its technical proficiency, then we could really be subsumed by another discipline, because you don't need, I can just teach somebody how to put in an IV. I can just teach somebody how to draw blood. These are, and we've done this, right? We've got phlebotomists, we've got respiratory therapists, and all, you know, very valid professions. But then why do you need me? If we can't really substantiate what it is that we bring to the game, and what we bring to the game transcends the medical, technological, and diagnostic circumstances of the patients that we serve. We are the gatekeeper. We are the person that helps everyone else see this individual as a whole, intact human being with feelings, emotions, and experiences unfolding that we need to be responsive to. And so what Dr. Watson talks about in her research is this idea of caritas processes. And caritas is a word, it's a Latin word, and it means more than caring. It's actually more about like nourishing. It's a very holistic, all-encompassing way of caring. And she's identified 10 of these caritas processes as part of this new world vision that she has of nursing, where she talks about it as caritas veritas. And veritas is truth. So what she talks about is this truth, all-encompassing, unified togetherness that we try to create with every caring encounter. The processes, I'd like to just kind of walk through these if it's okay with you. You know, and they go both ways, right? This is certainly about the patient, but it's about ourselves as well, because again, if you remember, you cannot give what you do not have. And so practicing loving kindness, she begins by saying with self and then others, because by fanning the fuels or the flames or the embers of loving kindness within you, that fills you up, that you can then bring that loving kindness to other and nurture them. Being authentic and enable faith, hope, and love to be the pervasive experience of the patient. There's bad stuff that happens in our world, you know, in the hospital world, wherever you are, right? Whether you're hematology, oncology, whether you're in the newborn ICU, whether you're working in the adult ICU, wherever you are, there's tragedy. There's painful experiences. There's loneliness. There's certainly this COVID pandemic is showing us a lot about the tragedy that befalls people in the hospital environment. Our job is to bridge that loneliness, to bridge that suffering, and to be that presence, that healing presence that can transcend all of that with just the smallest action. And how we do that is by fostering spiritual practices. And as I say the word spiritual, spirituality is like kind of like the umbrella, and under that are all these different practices that folks partake in, right? Spirituality isn't religion, but religion is one dimension, right, of spirituality. Some folks, their spiritual practice is running. Some folks, it's yoga. Some folks, it's going to church, so, but whatever that spiritual practice is that fills you up and restores you is something that needs to be a core self-care activity to help, again, restore you. When we bear witness to the most tragic things that can happen to human beings, it takes a toll on us. The work of Laura Vandernoot Lipsky, this is a social worker, brilliant author, did a fantastic TED Talk. She's got this really great book, and it's called Trauma Stewardship. And she talks about, I think it's 16, I can't remember for sure, trauma exposure responses that you'll see in people that work on the front line of humanity, right? Nurses, doctors, policemen, public defenders, teachers, social workers, all those folks. And the thing about it is, it's an insidious response, right? It creeps right up on you. You don't even realize that you turn into some crispy critter who has no empathy at all for the world, because it's a slow moving thing. And we work in environments, a lot of environments, that don't emphasize the importance of nurturing the frontline folks. It's kind of like, that's your job. And it certainly is our job as individuals, but it's also the organizations that we work with. It's their job too to have a healthy, optimal workforce, regardless of the setting. Also societally, right? It's society's responsibility to create that sense of love and kindness and concern that we're seeing now in this pandemic. Developing trusting interpersonal caring relationships. It's not about managing the pain when you can. It's managing the pain every single time. That's what cultivates trust. It's consistency. It's authenticity. It's transparency. Forgiveness and showing empathy. The research around forgiveness is really fascinating, and that the inability to forgive is actually linked with lots of different musculoskeletal disorders like neck pain, low back pain, fibromyalgia. Very interesting when you look at some of those studies in the alternative and complementary medicine, the power of prayer and forgiveness and how it has physiologic effects. So we're really, this was Florence's vision, and this is certainly Jean Watson's vision, to really understand and explore where are all of these other dimensions of care, because it's not just medicine. Medicine is one piece, and it's nursing's job to really recognize that there's a larger healing world out there that we need to be aware of. The use of acupressure in caring for the infants with neonatal abstinence syndrome. Very effective. How many folks use it? It's not as commonplace as it could be. I think we're seeing more adoption of these alternative complementary therapies, but it's not mainstream yet. Using all ways of knowing. So there's book knowing, right? But there's also that gut, right? And I bet you everybody on this call, nurse, therapist, whatever you are, you've had those experiences where you've bellied on up to your patient or the incubator and something's off. And sometimes we struggle with identifying what is it. That's intuition. That's all ways of knowing. Something's wrong. It's pattern recognition. But sometimes we struggle in articulating that to get somebody else to come over. I think medicine is really opening up to this and becoming more aware that there are these other dimensions of assessment that we need to really, zoom in on, instead of just saying, well, we'll just keep watching, and then their belly blows up. There are all these different ways of knowing are valid. And what Jean and I believe nursing science in general is inviting us to is to turn back in and listen to ourselves, listen to the wisdom that lies within us. as healers, as humans. Because if you remember that slide before, we learn from others how to be human. And they teach us and we teach them. And so checking in our inner wisdom really opens up so much more information than us always asking someone else. And there's nothing wrong with validation. But when you validate, take that then as, I was right, listening to yourself, not second guessing yourself. Genuine teaching, learning experiences. This is, I love this because I love teaching, but it's really being open to, I learn from my students and they learn from me. They teach me, I teach them, right? It's that dyadic thing. This is such an important process when it comes to precepting and onboarding our new colleagues and shifting away from that eat our young kind of mindset, which still exists today, to one that is more loving, more kind, more authentic, more trusting, creating caring, healing environments for all that are involved in the care. And that's part of the core measures for trauma-informed care. It's all of the human inhabitants in the space, that environment honors the dignity of all. It meets the needs of each player, and valuing humanity, and embracing the unknowns and the miracles in life. And sometimes people can kind of look at you like you just landed from Mars when you talk about that sort of thing. But we all know we have borne witness to miracles. I have certainly borne my share of witness to miracles in the care of the NICU when patients, they were going to die. That was the end of it. And then with one moment, one encounter with skin to skin with their mother, that child had no intention of moving on to the next life. Those are miracles and we all bear witness to them. So I like how she kind of categorizes this so that we can really understand this is about us cultivating the greatest healer that we have within ourselves. Oops, sorry. Hit the wrong button. Oops, I did it again. And so she uses this concept of transpersonal caring, and she talks about these as caring moments. So transpersonal is really just about the person, right? It's about me. And I learned this concept, this therapeutic use of self, during the short period of time where I was a nurse manager in a adolescent psychiatric ward, when this beautiful colleague who's a clinical nurse specialist in psychiatry told me about the therapeutic use of self. I was terrified. I need to have my lab coat on and my pockets filled to the brim with everything I could possibly need. Throw a stethoscope around my neck, that's frosting on the cake. I'm good to go. If there's anything that patient needs, I've got it on me. Not realizing if there's anything that patient needs, I've got it in me. Do you see the difference? I mean, it's subtle, and maybe they need something that's in my pocket, but more often than not, they need something that's within me. And so I want you guys to get really close to this picture. Okay, come on, everyone, get really, really close to the screen. Zoom right in on this little person. I want you to just be with this little person. I want you to notice his skin. I want you to notice how smooth his brow is. The faintest hint of his eyelashes. That plump little curve, or curves rather, on his lower lip. You see his chest? I mean, of course, the nurse practitioner in me is saying, I think that might be a retraction, but I'm not 100% sure, but it's a static picture, so I have to cut myself some slack. But the overall view that I'm getting from this person is a combination of physiologic, psychologic, and existential information. Physiologically, I might see a retraction, but the brow is so smooth. He's unfettered by that. He's not plussed by that, right? Psychologically, his face is so relaxed, but with lovely tone. He's conveying to me that he's comfortable. And the word existential is really about like the meaning of life, the meaning of why things happen, right? From an existential perspective, what is the meaning for this child to be here in this moment? What is the meaning for me to be here beside this child in the moment? And it reminds me that this person is more than a collection of different parts. He's more than somebody who needs his feeding tube, you know, readjusted or taped down. He's more than an armpit that I have to access to take his temperature. He's more than, you know, a heartbeat or lung sounds that I need to auscultate. And I need to really take a moment when I approach this sacred encounter, right? This caring moment that Watson defines, to be fully present to the wholeness of this individual. That's what the essence of caring is about. The tasks are important, but the tasks are a vehicle for me to express my compassion and my caring for this individual, to honor who this person is and why are they here in this moment with me. Caring is the essence of nursing, and I'm happy to say that we're now in a place where our nursing theorists, nursing scholars are really getting it and recognizing, oh, I love all these comments, and recognizing that nursing science is much bigger than the tasks, that we don't need to be, you know, patted on the head and saying, you're doing a good job, little nursemaid, you know, thank you for handing me that scalpel. You know, that we are an independent profession and we are here to serve the needs of the patient, translate our observations to our colleagues so that they can make informed decisions and guide therapy. And this essence, this caring essence of nursing is grounded in trust, our consistency in being there for the patient, intimacy, right? I mean, how many people think of this, but we take it for granted. But these are very intimate moments in human life. You've just given birth. You might be dying. You might need help, you know, with your bodily functions. These are very intimate experiences that we need to honor and respect. That's our responsibility. It's our responsibility to the patient. And because of that responsibility to the patient, we need to be responsible to ourselves in restoring ourselves, in filling up our cup consistently and reliably. And this caring concept is the quintessence, in my opinion, of quality healthcare. And I think it's what really underpins our title, which I don't know how good you guys are going to feel about me saying this, but it's about being a healer. You know, we cannot cure everyone. Our goal certainly, you know, we'd love to have everybody survive. But survival without thriving, what is that? Is that really what we're trying to get at? And the way we approach that is through our healing presence. And again, that's fueled by our personal wholeness. Healing is the process of restoration of health from an unbalanced, diseased, damaged, or unvitalized organism. The result of healing can be to cure, but one can grow without being cured or heal without a cure. And just to kind of pivot back to the nurse theorist, there's this really cool nurse theorist, Margaret Newman, and her theory, nursing theory, is about health as expanding consciousness, where patients actually, you know, it's an existential concept where patients actually become even more wise, more attuned to the larger purpose of their life because of the suffering that they move through. You know, particularly people that, well, actually all kinds of diseases, you know, those acute catastrophic events, but even those chronic conditions where if you can successfully heal through that, you transcend the suffering. And that's a form of healing, right? This is an expanded understanding of the granderness of life, the granderness of existence. Is that a real word, granderness, or am I making something up? Please forgive any of my English or grammatical, the license that I take with the language, okay? Hopefully you get what I'm talking about. And one of my colleagues here on the call actually used this expression and I just loved it. We heal hurts. And whether those hurts are physical hurts, emotional hurts, spiritual hurts, or even existential hurts, we are being invited into their life, into that sacred space of who they are. We get to be there if we choose, right? It's a choice. I can belly on up to that incubator and I can get the vital signs. Or I can belly on up to that incubator, I can get the vital signs, but I can also be invited in to be with you and learn who you are and how I can help you. And in that exchange, you help me become a better me. That's the cool stuff. That's the essence of nursing. That's the essence of caring. And in the literature, which is just so exciting, it's this idea of caring really kind of hinges on this idea of spirituality, psycho-emotional, psychological aspects, and then the physical aspects of caring, right? And I kind of referenced that in the slide before, that idea of that existential phenomenon, that spiritual dimension of caring that helps you feel seen when you're lonely and isolated. The psychology of it, that even, when you're anxious or something painful is going on, if you're with me, I can get through it easier than when I'm alone. And in fact, I think about the COVID stuff and how many of these individuals are, they're not able to spend time with their loved ones during those last few moments. There was one story published in the Globe about a patient who they allowed the wife to come in because it wasn't looking good for the husband. He was on ECMO, and they said she could have 5 minutes or 8 minutes, some silly small amount of time. And as this woman sat with her husband and stroked his arm, medically induced coma, and she told him, I'm touching your arm, I love you, all these wonderful, beautiful things. The vital signs on this patient started equilibrating, right? Getting into a better place, oxygen saturation, improving dramatically. That 5 minute or 8 minute time frame went into 3 hours. They allowed this woman to be with her husband. And when the physician was interviewed, he said, I can't rule out the fact that that's not what saved this man's life, because he did survive. He was able to get off ECMO and actually go home. We see that. That shouldn't be a secret. That's our secret power, right? That we know that, and we need to use that more. And I mean, the physical aspects of caring, are certainly important, right? Turning and positioning and, feeding people and doing all these other kinds of things that we do, but it can't be in a silo, because the power of it is it being all together. It's in the wholeness of caring that the magic happens. So in the first paper that I ever got published, that I ever had published, it was such an exciting time for me. And I got to work with these amazing, amazing clinicians. Sharon Gibbons, a PhD NNP out of Sick Kids in Toronto, Canada, and the late Stephen Hoth, neonatologist out of Cincinnati Children's Hospital. And he was also the director of the Skin Institute out there. So he was a skinaholic. I mean, he just knew everything about the skin. And it was amazing. He was such a great teacher. That the skin arises from the same germ layer as the central nervous system. And he would explain, so that really that the skin is externalized brain, and the capacity of the skin to sense and be aware and respond to stressors and interactions with the environment. And he was trying to explain to me that the skin during a care encounter is like a Mobius strip. A Mobius strip is one continuous loop. There's no inside or outside. It's all one thing. And you can kind of see it's twisted a little bit here in the image. And this was an excerpt from the paper that he wrote this. Neither the developing infant nor the environment exist in isolation, but rather intersect at this shared interface, the skin. In care interactions, there are not two separate surfaces bumping against each other, or two separate surfaces with an intervening space, but a single continuous looped structure, which is both the organism and the environment. And in a care encounter, when I have my hands on you, we become one new organism. That's the power of caring, to be present for that, right? I mean, we touch patients all the time, and it doesn't mean anything to us. But when we're present for it, when we're present for the sacredness of it, and the magic of it and the beauty of it, it changes everything. It brings us present to that moment with the patient. And so coming back to Watson, it's really about this idea of the whole person. It's, that unitary connection. I'm so sorry, I went forward. That unitary connection with all of humanity. It's transformational. And Watson invites us to adopt that worldview of nursing and healthcare, that we are all one. And I think this time now with the pandemic is really highlighting that, right? All over the globe, clinicians are caring for people who are critically ill, suffering, frightened, alone, isolated. This is a worldview, and who are being honored and recognized? Frontline clinicians, respiratory therapists, nurses, doctors are being recognized for this. We can't let this moment pass. This is the year of the nurse. This is the year where frontline clinicians need to stand in their power and shout it out to the world what we bring. That the gooey center inside is where all the power is. It's where all the magic is. So I'm going to ask you now to do this little activity. Everyone just kind of sit up in your chair, okay, or wherever you are. You're in bed or whatever, cool. Just sit. And I want you to just take a nice deep breath in through your nose, fill out your belly, blow it out. This is from Jane Watson's book. She invites you to take those nice deep breaths, continue to do the deep breathing. And she asks you to fall into your heart and open your heart to now, this moment, this breath of life. Listen quietly to your silent inner voice. And the first words that come up when I ask you this question, why are you here? Why are you here at this summit? Why are you in healthcare? Take another breath in deep, blow out your belly. Bring it back in. One more. And I want you to write down on your note paper, what were the words that came to you? Why are you here and why are you in healthcare? Don't overthink it. Don't make yourself crazy. Don't analyze it. Just those first thoughts that came to you. You guys are awesome. Now I'm going to introduce our panel because again, I've shared with you guys, the essence of caring, and I've tried to be even-handed, but I have a nurse brain, so my default setting is nursing. But this essence of caring, and kind of like the core message that each of us carries within our heart, is different, right? And that's the richness that we bring to the patient care experience. So I'm going to stop sharing the screen and open up for our panel to present what their take is, what are their core messages around the essence of caring. Our first speaker is going to be Christy Fuller, an occupational therapist from Iowa. She'll be followed up by Tara DeWolf, physical therapist from the Midwest. And finally, Shannon Frey, who's a speech-language pathologist out of Omaha Children's. So I'm going to go ahead and stop the share and put this on the grid. And then, oh my goodness, look at all of you guys. This is so wicked cool. You can't see everybody when you get the slides up. Okay.
Oh yeah, that is cool.
Christy, I'm going to have you start, okay, hon?
Okay. Well, hi. It is great to see you because I couldn't see everyone and now I can. And so that's really cool. Well, Mary asked us each to think about what we think about when we think about the essence of caring. And when I think about the essence of caring, I think about alleviating suffering And suffering is a universal part of the human experience. And I feel like now in COVID days, we're really feeling a lot of suffering. We see it every day. Did I cover me up?
Here you are. Yes, you got. No, I was
I'm
just going
sorry.
to message you going, I can't see you.
Okay, I'm here. I'm sorry. Okay. So we see it every day. And what does it really mean to alleviate suffering? And really, it's about being with one another during these times that are just so difficult. And in our world and in our work, we have the opportunity to really, truly be with. And so that's what I want you to think about as I have my little talk today, is how are we truly being with the patients and the families that we serve each day? They do remember how we made them feel. And in the end, we end up being invited to that, bar mitzvah or graduation party years after we've been a part of their experience when they were babies. And so I think that says a lot about the relationships that we develop during a time that our patients and families are just so vulnerable. So when we talk about the idea of being with one another, the word that comes to mind for me is empathy. And the definition of empathy is to become one with. And I feel like that fits in with that Mobius strip idea that Mary talked about. And it's a really cool word. And so I want to share with you where the word empathy comes from. The English word empathy was coined in 1909, and it was a translation of a German word. And I'm probably not going to be great with this translation, but it's Einfühlung. And it means in feeling or feeling into. The word first appeared in print by a German philosopher, Robert Vischer. He wrote a PhD in 1873 on aesthetics. And so Vischer used the word to explore the human capacity to enter into a piece of art or literature and feel the emotions that that artist had worked to represent. So it's imbuing a piece of art or any object with relevant emotions. And so if you can think about the days when we could go to museums and look at art, think about, you look at this beautiful painting or you see this amazing sculpture and it gives you a feeling. You feel something. There's an emotion there. And so I think it's just so cool to find out that the word empathy came from this German word, Einfühlung. And it just adds a really wonderful dimension, I think, to our understanding of the word empathy. So think about that, to feel into. As NICU professionals, we are called to feel what that baby is feeling because that baby doesn't have words. And so we have to feel and put ourselves in that position to say, what does it feel like to have all these things happen in one day for you, little one? Or what does it feel like to be separated from the most important person in your life? We also have to think about empathizing with the families. And we come into, contact with all different people from all different walks of life, and we don't know their story. And so just having empathy for the fact that they are in this unfamiliar situation. And I remember something in my life where I had to go to the hospital. My mom was sick. And, I come, barreling through the doors, no big deal. Don't even, notice really the hospital surroundings. And I was with my dad. And just going through the front door of the hospital was really difficult for him. And so I think, again, recognizing that the hospital's our environment. We're used to it. But that's not the case. So just getting through the front door may be really difficult for the families. The other person or people that we need to think about are the people that we're working with. And how are we being empathetic to them? Because they have stories. We don't know what they're struggling with. at home and how difficult their life is and the struggles that maybe have occurred over the weekend as they show up on Monday morning. And so just thinking about that feeling of compassion and love for all of the people that we are encountering. So I'm going to close with an example in my own life of when someone entered into suffering with me, and that I felt that amazing comfort, and it was an antidote to my pain. And so I think not downplaying the fact that being empathetic can be an antidote to others' pain, that being alongside, that holding their hand, and just leading with our heart, it gives us that capacity to really be with someone. So I'm going to tell you about Darlene. And Darlene is the nurse who stayed beyond her 12-hour shift with me to hold my hand when I was giving birth to our daughter, Emily. I remember being so frightened. Things were not going as planned. I had a really long day. And, you know, it starts with, I think we're going to need to put in an IV. And, okay, now I think you're going to need to be on some oxygen. And as all these things start to unfold, and also having my background in understanding that births don't always go well. They don't always go smooth, and there are not always great outcomes. And so I was feeling that, and I was feeling the stress of what was happening around me. And she made me feel like everything was going to be okay. And on that one day, she gave way more than her knowledge and skills, but she gave of herself. And she held my hand, and I made it through. And when we reflect on this, that was 23 years ago. And I still remember how Darlene made me feel. So I want you to reflect on a time in your own life when someone shared in your suffering by being with you. And I know that you guys will come up with numerous examples, because when I started this process, I thought of so many ways in which people had comforted and walked alongside me at those times when it was most important. So truly take some time and reflect on that. And if you feel comfortable, share in the chat box your example. I think that it will bring greater meaning to your own work, because you will know that this is what you remember 23 years later. So go forth and be empathetic. Thank you.
Thank you so very much, Christy. That was absolutely beautiful. I'd like to invite our next speaker, Tara DeWolf. Tara DeWolf is a doctor of physical therapy from the Midwest, and she's going to share her take on the essence of caring and her core message.
Hi, everyone. Can you hear me okay?
There you go.
Great. It's so good to be here. Thank you, Christy. That was beautiful. So the essence of caring, it resonates so much with me. And for the therapists on the call, would you guys agree that it really does take a mindset shift for us? You know, our early training is really in that habilitation, that rehabilitation model. And, but, you know, just like Mary said, working with the vulnerable, it's truly different. And so I feel like, you know, we are always caring, but we were caring in the sense of finding the deficits, treating them, you know, helping things move along. Whereas now I think about caring through that lens of trauma-informed care, and that sense of caring really for prevention. And, you know, to bring that loving kindness that Mary speaks of is so much more profound in every patient interaction. And so, you know, as I reflect on my own life as well, I really have been drawn to being caring from a very early age. You see, my dad had cancer as a child, and so it was miraculous that he even survived this aggressive cancer so young. But with that, in my childhood then, he started to suffer some, secondary effects of those treatments that saved his life. And so there were times in my childhood where I, just like took on that caregiver role, through surgeries and him on crutches and walking boots and IV infusions at home and a leg amputation. I wanted to care. I wanted to care for him. I wanted to stay strong for my mom, and I wanted to help my little brother, not really even realize anything was wrong. And so, as I think about that, and then years later, when his cancer returned, I was ready to spring back into action and, be that doer, be that caretaker. I was calling my colleagues for second opinions. I was, researching and explaining the medical jargon to my family. My dad was only 55, and, I was ready to do. But when the results weren't good and he decided that he just wanted to live out whatever time he had and forego any treatment, I was supportive, but my doing didn't work anymore. And so my essence of caring was different for my family, and I didn't really know how to respond. When you want to be the caretaker and someone's dying, there really isn't much to do. And so, looking back, it was all about just like the moment, just being there, as Christy said, like being with. And so for the babies that we care for, us as nurses, as therapists, physicians, practitioners, respiratory therapists, it doesn't matter. We're trained to do, but I think that about a quote from Mother Teresa where she said it best, that it's not about how much we do, but how much love we put in the doing. And so, in those moments, every moment when, we're with babies and families, what if we did that? What if we focused more on the love, on the essence of caring with each other, with our own families? I truly believe that we can create space and time, create a way for those moments. Maybe it's right at birth. Maybe it's hours later, days, even weeks or months later, if we set our intention to do so. Because we know that any child, any family in the hospital, or even then after their hospitalization, they're experiencing trauma. It's the very things that are saving their lives that are also traumatizing for them and their families. And, but it's my drive, it's my hope, it's my calling, I feel like, to just ease that a little bit. And I think specifically about a baby that we were caring for, and her parents were at the bedside often. Mom would come during the day and hold skin to skin. Dad would come at night. I thought was holding as well when he was there. And so this one day, Dad was there during the day, and Mom said that she wanted him to hold first. And she was quite sick. And so the nurse grabbed me and said, hey, can you come help with this transfer? And as we got everything set up, and Dad, took her in his arms, he just started sobbing, and he said January 22nd was the last time, and he was just stroking her back and kissing her head. And he had that date, which was weeks prior, we didn't even realize, it had been that long since he had held her. And, like that was a moment I didn't even know, I just thought it was going to be like another day, like here she is, you're so used to doing this. And, but it was so special and it matters. And specifically, while it matters for them, is that she didn't survive. And so, like every one of those, what seemed like just kind of typical mundane moments, interactions, it's like all they have now, memories of the moments with her. And so you've been there, we all have, we've seen it. And so I just ask, what if we created more time for sacred moments for mamas and their babies, for dads and their babies, for families? What if among all the trauma, we could remember how we, the healthcare team, treated them? What if that's what they remembered? How we empowered them to care for their little one, or how we eased up that suffering even just a little bit. So as I reflect on the essence of caring, my hat also is off to you, Mary Coughlin. Just like Florence Nightingale, your passion and your ability to pioneer the way for all of us to challenge ourselves in every moment. And then I ask you guys as well, what are those moments that come to mind? What can you think of? When have you created that time and space and witnessed maybe something bigger than you even realized? Or maybe there's perhaps a circumstance where you feel like there was a missed moment, that next time you'd maybe do something a little differently. And so please think about that, write it down for yourself or share in the chat box so that we can all benefit from your moments as well. And thank you so much, everyone.
Oh, okay. Thank you very much, Tara. That was absolutely beautiful. I really appreciate you being so honest and all that. So, excuse me. Our last panel presenter is Shannon Frey, speech language pathologist out of Omaha Children's. She's going to share her take on the essence of caring and what her core message is for all of us. Shannon?
Hello, everyone. Wow, those were some powerful messages and difficult to follow. Beautiful. Thank you so much. When I think about the essence of caring, I kind of think about my journey towards becoming a speech pathologist and what drives me throughout my career. So my journey towards becoming a speech pathologist actually began in the pediatric inpatient unit at the University of Iowa Hospitals and Clinics when I had met an 11-year-old boy named Sergio. As a volunteer in the unit, I had tutored children who were inpatients for extended periods of time, and many of the children had a diagnosis of cancer. Typically, I would meet a child within days of diagnosis, and Sergio was no exception. A week before Sergio's diagnosis of acute myeloid leukemia, he had been attending school, playing soccer, and was an active participant in Boy Scouts. Then, suddenly, he had an IV pole attached to him, was learning how important blood cell counts were, and was living out his life at the hospital. The only normal thing that remained in his life and that he still needed to learn about was prepositions, long division, and the history of the United States. And that's where I came in. Sergio and I met for an hour each day and worked on the same coursework his peers were doing in the classroom. Even on his sickest days, Sergio would insist on doing his homework. He knew that each day we worked through homework, he was one step closer to achieving his ultimate goal, which was leaving the hospital cancer-free and returning to his life as an 11-year-old boy. An hour each day may not seem like a lot, but for that hour, Sergio was not only reminded of his life before cancer, but was also making small, measurable steps toward his end goal of leaving the hospital cancer-free. Although Sergio never ultimately reached that goal, he taught me that happiness, even in the most trying times, can come from small victories along our own journey. This little boy changed my life and taught me many lessons in our hours together, and ultimately helped me find my calling to help others thrive. I followed that calling, and 5 years later began my career at Children's Hospital and Medical Center in Omaha, and had a passion to work with patients who, like Sergio, had extended and long hospitalizations. Children, babies, and families who were impacted by congenital heart disease, prematurity, BPD, childhood cancer, brain injuries, and other diagnoses that led to months and even year-long hospitalizations. How could I help these children and their families thrive in such an environment that is not conducive to development? How can I help to normalize these traumatic hospitalizations for these families? Well, I did my best at the time and used what I knew to help these children and these families. I felt like there was something missing. Life ended up transitioning me closer to home to Illinois, where I ended up in a clinical setting that I swore I would never work in, the NICU. The NICU had always been a clinical setting that intimidated me, and my previous mentors in my professional career had instilled in me that the NICU was an environment where, as professionals, we can do harm. It is a specialized area of practice, and where new clinicians should not practice without mentorship. But as it turns out, God had a plan, and within a few months of starting at that hospital in Illinois, 2 therapists from out of state were hired, and my official NICU mentorship began. During that time, I was introduced to the lovely Mary Coughlin and trauma-informed care, and truly how this care can help babies and families thrive from the earliest moments of their life. A hand to grasp, a gentle touch during something painful, skin-to-skin experiences, even for the most critical babies, uninterrupted periods of sleep, and families feeling empowered through their babies' hospitalizations physiologically changed these babies' brains. This care changed the trajectory of their lives in order to help them thrive, despite their early and critical start to life. Little did I know, walking into an 11-year-old boy's hospital room to help him with homework would lead me to my calling, helping others thrive, despite what is put in their path along the way, and no matter the outcome in the end. It's about the journey to the end, and everyone deserves to thrive. So I just ask you guys, when, thinking about families and babies, Mary had mentioned this in her talk, but thinking about the difference between thriving and just survival and how that looks for these families, especially with families and babies, especially thinking about all the medical advances that have come and our role in helping them. I know there's a lot of therapists on their call, but what their life looks like after they leave and the impact we can have on that. So I will turn it back over to Mary.
I forgot I had muted myself. Thank you so very much, you guys. That was absolutely beautiful. And I'm hoping we've got so much going on in the chat. This is like so wicked exciting. I'm actually able to save the chat content as well. So I'll upload that onto the site with the recording so everyone can have that experience. But I would absolutely love to hear from you guys. What's your take on what we've been sharing? What stories do you have? What does the essence of caring mean to you? And I know we've got lots of folks here, but maybe if you are able to raise your hand, I know there's a little hand option there, and then we could call on you. So it just, it doesn't end up being people talking over each other. Does that sound okay? And I think where you go, where you raise your hand is if you go into the participants and you pick yourself, there's like a little option to raise your hand. So, and I'm just going to keep scoping out to see a hand raised. Okay, I'm looking. I must look like a crazy person trying to look at all these beautiful people that came. Denise has raised your hand. Okay, awesome. Denise, if you wouldn't mind unmuting yourself.
I think I'm unmuted.
I've got you.
Can you hear me?
Yes.
Okay. Great presentations. I loved everybody sharing and kind of those personal experiences. I think we've all felt them, and I think that's how we do get back to why we're doing what we're doing. It can be so easy to get caught up in the everyday grind of it all that we kind of lose that. And so to take, that's one of the things with our current situation that I've really been blessed by, is the time to really kind of step back and think about why I do what I do, and how that motivates me. When we did our little relaxation exercise with you, some of the words that came to me were touch and love and oxytocin. That's the nerd in me. And I think the one word overall that I resonated with is empower. I think in our roles in the NICU, whether it's nurses or therapists, one of the greatest gifts we can give to parents is to empower them to step into their role as parents. When you look at the meaning of the word empower, I think the first thing is it's a verb, it's an action. And when parents come into the NICU, when I think about my experiences as a mother, I'm just going to tell you I'm a baby lover, and my house would be full of kind of baby anything. I love pets and humans, but as the mother of 5 and a grandmother of 7 and a foster mother of 10 infants over the course of 12 years, I love babies. I love the little exercise you had us do about looking at that picture. I'm mesmerized by babies, by their movements, by their vocalizations, by their soft, sweet skin and the smell of their heads. Everything about a baby just gets that oxytocin flowing. Doesn't even have to be my baby. But when I think back on those experiences and those deep feelings that are associated with that, and then I contrast that to what I see every day in the NICU, I see parents sitting beside a plastic box, and I see them feel isolated and lonely and scared and fearful and totally disconnected. And so I think the first part of empowerment is we have to give them permission to step into that role, because they realize that they're not in control. They don't have the medical knowledge, and quickly they feel like somebody else can do it better than them. So I think that's the first step. It's an action on our part, and we have to be intentional about that. The meaning, I looked it up, is to give or delegate power or authority to, or to give qualities or abilities to. And I think that's where we can really step into this. They feel like they don't have the ability, and we have an opportunity to help them see what their baby needs from them is not the medical knowledge and all of the skills we're able to do, but it's their presence. It's that touch. It's that smell. It's being together in relationship. That's one of the things I loved about your quote about Gene Watson. It's the belonging. It's the relationship. Yeah. And if we don't start that from day one, I think that changes the trajectory of both that baby's development and that family's development. And we can either empower our parents to step into that immediately, even if it's just that touch in the very beginning, you know, or their voice or their smell. But if we empower them and help them understand what their baby needs from them is something we can't provide.
Exactly.
And then, you know, from there, as that baby matures and is able to handle more, really, you know, so by the time that parent goes home, it's not all about, let's do all this discharge planning now because you need to learn how to parent. They already know, and they're, you know, so what a great, I mean, it's just, it's so fulfilling to me to have those moments where I see a parent really be able to be a parent because I have given them the authority, and I've given them the qualities and the abilities. I've shown them, you know, how to do a swaddled bath, and it's not about the task, it's about that relationship and enjoying that experience together. And, you know, so as a therapist, I can give them the tools that give them the ability and the knowledge and the skills so that they can parent and they can see this as a joyful experience instead of that scary, traumatic experience that it is.
Absolutely, absolutely. I've got Kara Sorrells is raised her hand, and then after that is Susan. Kara, do you know how to unmute yourself?
Yes. There we
Awesome.
go. Okay. Hi. So I'm a mother. I had triplets at 25 weeks, and now I run the NICU Parent Network. And I just wanted to, I mean, everything that Denise was just saying really resonated with me from my experience, which was 13 years ago. But that really is the greatest gift that you can give a parent, is to empower them. And you know, the NICU is such an unnatural place to be a parent. And I really just, sorry, I'm starting to get a little choked up, and it's been 13 years. So you see how, you know, how impactful that the experience is. And it is those nurses and those therapists that, that took that extra time to teach me and to hold my hand. And, you know, when I just was sitting there staring at my baby, they were the ones that said, get your hands in that isolette, you know, hold your baby. I mean, it just really, you know, I just wanted to say thank you to those of you that really understand and take, you know, everything, that really take that to heart about what a traumatic experience it is, and the key role that you really do play in how these parents emerge from the NICU. Because, you know, that time in the NICU is, I mean, it's just a blink in the time of the child's life, but it really does set us up positively or unfortunately negatively in some ways, and how we're going to be able to advocate for our children, and how, you know, how we feel in terms of our confidence, and how we're able to even heal from the trauma ourselves.
Our mission here with Caring Essentials and Trauma-Informed Care is really to make that the standard, and not the standard that like is up on the shelf, you know, that it's living and breathing in NICUs and PICUs and any place where families in crisis are served around the globe. So I appreciate you sharing that that powerful story. God bless you. Susan, if I could have you unmute yourself.
Yeah, I just did. It's Sue Bowles, Mary.
Okay, Sue, how are you?
I'm good. How are you? I just want to say, and I think I want to tag on to what Kara just said as well, is too often in our NICUs, we view the parents as visitors to our units.
Yes.
We're visitors to the parents' crisis, to their life, to their family. They don't visit our units. We're the visitors, because we're there for such a short period of time.
Right.
And that's the hardest thing to try to get people to understand. And also, we have to understand this isn't the bedroom they thought they were going to get. And I think that's one of the biggest things that I always talk to the nurses that I work with about. This is the baby's bedroom. How would you like somebody in your bedroom at 3 a.m. flipping on all the lights, busting at you, doing that, doing the other thing? You've got to remember that this is a baby, And this is a baby that's still forming and is still learning things and is still trying to understand what touch is. And the family's doing the same thing.
Yeah.
So, and the other piece I always try to bring out is the crisis piece, because I don't know about anybody else, but I'm not the nicest person on the planet when I'm in crisis. So why do we expect that the parents are going to come in every day with a smile on their face and be happy and wonderful and, but if they don't do that, they're rotten parents, or we don't want to take care of them because they're not so nice.
Right.
So we have to really remember that this is a whole different ball of wax than what they signed on for.
And, Sue, I love that you said that, because I think that also just highlights the relevance of this idea of a trauma-informed approach to care. Certainly I'm obsessed with the NICU, but it's in any clinical setting that this is a traumatic event, and understanding how we, just as humans, besides your alphabet soup or just as human beings, how traumatic experiences disrupt our auto-regulation, disrupt the way we're thinking, the way we show up. But we don't get trained in that, right? At least I didn't, and so I think that's why this idea is just so profoundly relevant for families in crisis and the work that we do. So I'm so glad you pointed that out about, parents coming grumpy. Well, I'd be pretty grumpy too if my infant was in a life-threatening situation.
Yeah,
God love you.
absolutely.
Thank you so much.
No worries.
Susie, and then I've got Jessica.
Can you hear me and can you see me?
Both.
Can you hear me okay?
Yes, I can. Everybody else? Yeah.
Okay. Because I'm sitting in my van at a farm for 8 days and self-caring. So, but I wasn't going to mess up or anything. So anyway, I just wanted to add, to expound on what Sue said, and Mary, you, and really what everyone has said. But in the NICU, I think in the part of trauma-informed care that is so important, and that I have learned through compassion courses and things, my core message is compassion. I believe that everything we do is really based on that. And I like to explain to people, it's called Just Like Me, where, for example, you go to a baby's bedside and you want to be intentional in your caregiving, and you look at that baby and you say, just like me. If I was in the situation, I wouldn't want the covers ripped off. I wouldn't want the lights flipped on. I would want to be touched gently. Just like me, the parent sitting at the bedside has a loved one, a child, that is hurting as I would hurt. And if you get the grumpy caregiver that comes in, or the grumpy parent, grumpy nurses, the Barbaras, as you say, Mary, that just like me, I have bad days too. And that you put yourself in someone else's shoes. And that feeling of empathy, which compassion is the action upon the feeling of empathy, makes things just seem so much more, I don't even know the word, it has such an impact on me personally, that I view the patient, the family, my coworkers, everyone, we're all in this together. No matter who you are, we're all as a team. And I love what you said, Sue, about the parents being, the visitors. And that is so true, that we flip the sides, and just like me, I would want to be the main caregiver as well. So anyway, that's just my
Thank you.
take on it.
Thank you, Sue. Thank you so very much. Jessica Thomas?
Can you hear me?
We got you.
Okay. So I appreciate everybody's sharing, and I just wanted to share my own personal thought. I'm on a developmental care team, and one of the families I specifically follow is resistant to some of the diagnoses we have put out there, and our team wants to trach and do these things, and the family is not ready. And I fully support my parents. It's such an interesting mindset right now where I walk up and I have a respiratory therapist giving me a report, and they're like, and we need to trach. And I know that they've had this baby 2 days. And I can look at them in the face and I can say, this baby is 7 months old. I know these parents have been at this bedside every single day, and they know her better than you. No matter what you know as a clinician, they know who she is, they know how she moves, they know what she loves and doesn't love. What we as clinicians have to do is think outside the box and think, well, how can I make her stronger with the barriers that they want to continue putting up? Because it's their right to put that barrier up and say, give me more time before we trach her.
Yeah.
And so we as a team need to think, how can we set her up and get her to play and get her to self-soothe and grow her stronger, so that maybe she still doesn't need a trach in the long run, but the parents see that she is doing we are doing our part, but she's also receiving the love and care from us that she deserves. Yeah. And I just love that I'm not the only one on here that believes that. I know it.
No, you're not. You're not. And it's hard when you're in the thick of it to, when you're looking for a solution, because the solution is generally something that, you wanted it to happen maybe way back at the beginning, creating those collaborative relationships with families, empowering families, all those. It's a crisis, and really feeling with the families through this really helps you. But I think what you said is absolutely true, and I wish that there were simple answers to these complex situations. But I think we all have to remember that, unlike a lot of the way we address the cares for the patients, where you stick a tube in, you put a thermometer under their arm, unlike those things, caring for the hearts, minds, and souls of these amazing individuals is messy, right? It's complex, it's dynamic, it's beautiful. But if we don't do this consistently and reliably, these are the experiences that families in crisis are going to have. And I love the word that Tara had used earlier. What we're talking about here, in my head, okay, is taking developmental care to that next plateau, that we know the cares. We know what the evidence-based best stuff is. We know swaddle bathing's awesome. Skin to skin, oh my heavens. I think everybody should be ODing on skin to skin, right? I mean, that's quintessential, right? The biggest bang for your buck, do that one. What we need now is the mind shift, the mindset shift rather. We really need folks to be able to reconnect with their why, reconnect with their shared humanity, and not be afraid to express their emotions, their passion, their compassion, respectfully, right? Collaboratively, lovingly, but partnering with families beyond the partnership. Partnering with families isn't like, here's the thermometer and you can do it this time. That's not a partnership. It's about the collaboration. And I think if you'll indulge me, I'd like to just share with you a little more information about, the kind of the direction that, or the journey that I've been on, and then the direction where I see us going now in caring for families in crisis. Now that we know these best practices, we know these little people are speaking to us. We need to open our hearts and open our minds to what they're saying to us. I mean, when I think about the amazing work, right? I mean, literally pioneering work of Dr. Al's, right? And the NIDCAP model, and being able to read the baby. These individuals are speaking to us. They are trying to express how they feel, what they need in these moments. And I think still, 2020, we're still hung up on reading them. And I think the reading really comes from being present. right? Being present in those moments, those transpersonal caring moments. And I share this acronym with folks a lot. It's from Joan Halifax. She's a Buddhist monk who did work with palliative care and end-of-life clinicians. And she noticed that it was a high degree of burnout with this population, and she came up with this acronym called GRACE. And I, of course, immediately grabbed it and have been sharing it with my NICU colleagues. And it's really about taking that moment of grace before you put your hands on that person, before you begin the conversation with the family. Practicing grace, which is G, gather your attention. Internally, quietly, taking a breath, gather your attention, and R, recall your intention. A is attuned to the situation, not your tasks, the situation, the context, attune. And based on that attunement, consider what are your options. And then you engage. And then when you finish your engagement, you end. And your end is like, it's like framing a beautiful picture, as somebody had put in the box in response to Tara's, or maybe it was Christy, I forget now, I apologize. But art, right? It was Christy, you know, frame that piece of art that you've just created with that caring encounter with an ending. And that's not, you know, saying, okay, bye to the grown-up, or nailing your patient down and closing the doors and walking away. But it's framing it with a compassionate action that reconnects you to that person and communicates, all set, we're all done. And that's really, for me at least, you know, kind of all of that stuff really embodies this idea of trauma-informed care and the clinician. I mean, when I first introduced this idea, it was all about the baby and the family, which is absolutely my primary focus. But to get to the baby and the family, it's through the clinicians. And so clinicians need to be trauma-informed for themselves. They need to understand their own story, their own journey that brought them to this why they're here in this moment, why they're a nurse, why they're a therapist, why they're a physician. Yet you really need to own that and connect with it and check in with it. Because this isn't the work of any trained person. Although I know we have any trained person there, but we need to kind of tighten up the ranks a bit, in my opinion. You know, we need to set real bona fide standards. It's lovely that you want to come into nursing, but I'd like to see these particular attributes, these particular competencies. Just because you're a rock star at IVs doesn't tell me that you're going to be the ideal person for caring for families in crisis. It doesn't mean that you can't learn to do that, right? I mean, obviously, but I think we just need to really re-examine, you know, how we're bringing folks on and how we're operationalizing the care that, I mean, it's excellent care. It's excellent physical care. Excellent. We save lives. It's excellent work. But I really want to challenge you in saying caring isn't just about the physical dimensions. It's about the psychological and the existential that really, you know, prove to us that we're really bringing a holistic approach to the care, bringing our A game. It begins with you. And you guys should have gotten in the email this little like self-compassion like worksheet. And it really is about helping us, you know, as clinicians, take those moments to discover, what do we need? What are the self-compassion prescriptions that we can prescribe for ourselves, or actions that we can take for ourselves that help us, that protect us and provide for us and motivate us as we're acting in the world, right? Like in the work that we do with our families, in the supermarket, you know, what are those things? We need to reconnect with who we are. And that wonderful, beautiful soul that has come here to do this amazing work. And that's the being with ourselves. What comforts us? What's soothing to us? What validates us? Oftentimes we look outside of ourselves for things to comfort, right? You know, that, what was that movie, you know, with Jerry Maguire or something? You complete me. well, that sounds really good on film, but you complete you. And you need to build the courage and the belief that you are enough. Because if you don't believe that, how can you bring your authentic, wicked, awesome A game to the amazing, noble work that you've been called to do? So there's this whole other dimension now. It's developmental care. It's us developing our own awareness of the beautiful souls that we are so that we can then bring that to the patients. Because when we connect it correctly, we then confer to the baby our acknowledgement of the beauty and value of them as fellow human beings, and not just a 26-week body in the bed that I need to flip and strip and do up because it's 8 o'clock in the morning, right? It's all mindset. I'll probably say a swear word as I'm combining mindset and shift together. I apologize. It's not intentional at all. And I want you to take some time and do that activity. I want you to not be afraid of listening to your inner wisdom, because you actually don't need somebody else to tell you. You have all of the wisdom within you. You really, really do. And this is coming from somebody who never really believed that. And now I've discovered it. And it's beautiful, it's empowering, it's freeing, and it allows you then to really be the beautiful, courageous advocate that you're called to be in service to these amazing families. I got to work with, I think it's 12, good number. It's a 12 or a baker's dozen, 12 or 13, amazing international, interdisciplinary clinicians in neonatology to develop a trauma-informed certification. And in the journey of developing this, we wanted to identify what are the attributes of a trauma-informed professional. These were the attributes that we identified. We felt very strongly the individuals need to be knowledgeable. They certainly need to be knowledgeable and competent in the cares and the delivery of different therapies and all that kind of stuff around neonatology in general. But they also need to be knowledgeable in early life adversity and the epigenetic modifications that happen when individuals are experiencing unrelenting trauma, when they're not having their pain and stress addressed, when their separation is protracted, all these types of things. So knowledgeable. But then you'll notice what else is on the first column. Authentic presence. They need to be connected with their who and their why. Personal wholeness, self-care, self-compassion. That's your homework assignment. And hopefully those elements will help build your courage, because it takes courage to be an authentic advocate for patients and families in crisis. It takes courage to be a role model. It takes courage to come up to your colleague and say, hey, looks like you're doing a painful procedure. Let me help you. And maybe your colleague says, no, I'm all set, I don't need you. And then you can very respectfully let them know, oh, I'm not here for you. I'm here for the patient. I'm going to support the patient. Or, hey, look who's here. Dad, you're doing a heel stick? Let's facilitate some skin to skin so you can do the heel stick. Now, I know there's a lot behind that, right? I mean, I certainly don't want a clinician doing a heel stick in skin to skin if they're nervous and they're uncomfortable. There's ergonomics around that. But do you understand what I'm saying? You know, it takes courage once that becomes the standard to step up, because we've got lots of different personalities. Sue mentioned, you know, the grumpy parents. We've got grumpy nurses, right? I mean, we've got grumpy people, and we need to help each other kind of let go of the grump and really show up. But that takes self-care on their part, but it takes courage and love on our part. It takes a trauma-informed mindset, because maybe Barbara, that's my grumpy Gertie, maybe Barbara has been bearing witness to so much trauma over the past 20 to 30 years in her nursing career, she doesn't even know she's a grumpy Gertie. Really, she really doesn't even know. Because remember when I talked to you about that trauma, the trauma stewardship idea and stuff. So that's, these trauma-informed professionals really help across the continuum. The role model and scholarship. That's not just about, feeding your knowledge, but also presenting, being scholarly, pursuing different avenues, doing research around this idea of a trauma-informed approach. Trauma-informed care has its roots over 50 years now in behavioral health. It's new to the party in the NICU, PICU, and pediatric world. It's gaining some momentum, but it's not mainstream yet. So we need folks to do this research, connecting the dots. And in doing that, you become that leader for change, which is wicked awesome. And that's, it begins with this shared belief and shared vision around the essence of caring and the power of caring authentically, genuinely, transparently, openly, letting everybody see your gooey center, because that's where the power really is. And it doesn't mean that you're not smart and technically proficient and all that other kind of stuff. Oh, so I have to see, somebody wrote this. I appreciate the advocacy bullet point, which is so important for vulnerable. Absolutely. Absolutely. Being small, being pre-verbal, the cultural challenges, as Kira had mentioned about, coming into a NICU environment and it's a completely different land. All the jargon and all that kind of stuff, that's a big part of the role that we play. It takes courage to be an advocate, but it is, in my opinion, our absolute responsibility. Just so you see where I'm coming from, this idea of trauma-informed care, I was introduced to it back in 2013 and have just, been doing a lot of due diligence in understanding it, writing about it, sharing, what I've learned about it, presenting it in the different educational offerings that I provide. From our big program, it's Quantum Caring, and that's really about cultural transformation and really hardwiring these principles and practices of trauma-informed care, which is about safety, collaboration, choice, empowerment, and trustworthiness, and marrying them to the core measures. The core measures are, about the healing environment, activities of daily living, right? Posture, eating, and skincare. It's about mitigating pain and stress. It's about sleep, and above all, it's about the family and their consistent presence and empowerment and emotional well-being of the family. A Quantum Leap, and I feel so blessed that there are some Quantum Leap grads and Quantum Leapers on this call. It's all virtual as well as the Quantum Caring now. Quantum Caring was blended, but now it's all virtual by decree of COVID, but it's all good. Quantum Leap is about individual coaching and development to create these courageous and authentic leaders who can continue to champion trauma-informed care. The goal of this is to bring this across the world. I just got an email earlier today from this beautiful woman who came to one of the workshops, and she actually came to one of the Science and Soul conferences which is how I met her. She's from the Las Vegas area, and she's now going to pursue work in Africa, and taking this idea of trauma-informed care into that environment where there's lots of obstetric, the word she used, mutilation and that sort of thing that is really challenging the health of these women and young girls over there. And, she was talking about, bringing this concept to that area. It has global relevance, right, and transcends all patient populations. We also have online classes, but just to kind of like the take-home message is it's grounded in the science around trauma-informed care, and it's married to the beautiful work of Dr. Heideley Sals and others, championing this idea of developmentally supportive care. We need to respect these amazing people that we're invited to serve in ways that go beyond their diagnosis, go beyond their illness. So I want to just kind of give one last opportunity for the faculty, if they'd like to share any comments, to just go have at it before we do our final exercise, where we're going to ask y'all to share your greatest insight. And if you have courage, we're going to ask you to share it to the group at large. So go ahead in your note paper while the faculty thinks if they have anything else to say as well. And just write down, what's your greatest insight from today's summit? You can share it in the chat, you can share it verbally, you can write it on your paper, but it would be really amazing if you could share it to the group.
Thanks, Mary. It's Tara. Can you hear me?
I can hear you, yeah.
Great. Okay, greatest insight. I am a quantum leaper that she mentioned, and at the end of every call, we're always asked this, so it's important to be prepped. But I think that, it's just amazing looking at the chats, and, I feel like this group here on the call today is just, it's so humbling to see how everyone is, really stepping up and really wanting more, and really, making this about those that we serve. Yeah. And so I just want to thank everyone. My insight is all of the people who have stepped up and commented and shared. And so thank you so much. And it does look like we have two people raising their hand too. So excellent. I would love to hear what they have to share as well. Yeah. Thank you so much.
Oh, thank you so much, Tara. Gretchen? Oh, look at this. Awesome. Gretchen, are you okay to open the mic? Oh, there you go.
I'm ready. Mary and the rest of your panel colleagues, first of all, I really want to thank you for the opportunity to be able to attend this virtual summit. I don't have the opportunity these days to really get out to a whole lot, and I'm managing to accomplish this while I'm at work, so that's fantastic. I really appreciate, I've followed your work in writing, but not in person, Mary, for a number of years now.
Oh God, thank you.
And I think, the essence of caring is truly the same as, and again, I apologize to the non-nurses, but it is all about the essence of who we are as nurses. And definitely feel a kindred spirit in listening to your presentation. There were a couple of, and you probably know this work, but a couple of avenues that informed me in similar ways was Susan Reverby's work on the history of nursing and ordered to care. And I can send you these if you're interested, because
yes, please.
It's totally what you're getting at, and you would identify very well with this work.
Thank you.
And then the other is something I just read it by chance at some point, but in 1990 and I don't think the work continued, but there was a nurse named Jan Pettigrew who wrote on the Ministry of Presence. And that's exactly, when I raised my hand, I wanted to talk about Ministry of Presence, and then you came back on and made comments, and that's exactly what you talked about.
Oh, good. Oh, good.
The Ministry of Presence. And I think that very much is at the heart of caring. The work we do with babies when we form relationships instead of doing two, the work we do with families, obviously, in supporting families and getting to know and care for and nurture their babies despite the environment of the NICU. And also, I'm hoping and increasingly see the work that we do with one another as colleagues, both within our own discipline and across disciplines, in sharing the common goals of supporting babies and families. So mostly I want to thank you. It's very interesting to me to completely identify and feel the very heart of what you're saying, but you've built a very unique and different framework and different angles to look at it. And I think the more angles we can look at this,
right,
the more informed we are.
Yeah.
So thank you very much. And it's great to see all of you on here.
So awesome to have you here. I don't know if you probably don't remember me from Adam, but I started at the Brigham Women's Hospital.
Mary, the last thing I would have said, but I was trying to be a little more whatever, was, and I just love listening to you because of spending the 80s in Boston, and I feel like I'm in Boston listening to you.
Oh my gosh, I know you're a big cheese, you know. So when I saw that you had registered for this, I was like, oh my goodness gracious, this is so wicked awesome. So thank you so very much for joining, and thank you so very much for sharing that. I have heard the name Pettigrew, but any of those references I would massively appreciate. Thank you so
Sure,
much.
I'll send them.
Oh my gosh. Oh my gosh, look at all these hands. All right, Judith, thank you, Gretchen. Judith, and then we'll do Sharon and Susan.
Okay, so let me see if I can do this or not.
I have faith in you, girl.
I don't seem to be starting my video, so I guess I won't be able to do that.
We can hear you.
Okay, so I was going to show you a picture, but without that, we can do it anyhow. So at the beginning of this, you talked about back in the early days how it was a question of getting permission to do our tasks. And there was a lovely tribute written this week in LinkedIn by Dr. Gil Wernowski from Children's National Hospital, and some of you may know him. He is from pediatric cardiology and cardiac critical care. And he wrote, "To my colleagues in nursing, Happy Nurses Week. All the stuff," and he has a picture of the baby who is the room's completely full of every device in triplicate that you can think of, is managed by nurses. The baby is sung to by nurses. Nurses translate and reinforce what I say to the families. Nurses are on their feet most of 12 hours in a row. Nurses are, in capitals, the most indispensable part of the best team sport ever. Then there's a quotation: "Neither monitors nor the most complicated electronic gear makes a coronary care unit. The fundamental ingredient is a properly indoctrinated nursing staff. The reason for this is obvious. The nurse is usually the only trained medical professional at the bedside during important clinical events. In fact, many well-functioning units have been successful because of the elite spirit and competence of the nursing staff." This is a quotation from Dr. Bernard Lown in 1968 in Scientific American.
Very cool. You have to share that. Can you tag me in the post or however that works? I don't know how that works.
I'm not sure how to do that, but I can send it to you.
All right.
How's that?
That's perfect. Thank you so very much, Judy. I really appreciate you sharing that.
Sure.
Take care. Happy Nurses Day.
Happy Nurses Day to you, Mary. This was a wonderful, wonderful seminar.
Thank you so very much. And then we've got Sharon.
Hi.
Hi.
Wow. Gosh. So what I've been writing notes this whole time, but my biggest insight today was probably connection. If I was just to put it into one word, is connection. And I think this is so powerful to get together like this, even though we're in this time of crisis and being separate, but we're connecting this way. So I thank you for setting this up for us. And just putting everything everyone talked about today, I wrote down that we empower not only our parents, but each other through this connection to do the work that we do in trauma-informed care to alleviate suffering, to create these sacred moments so that our families, and not only our families and our babies, but ourselves can thrive. And that's been my biggest insight today. And of course, you know, I can't not say that this all gives me hope to continue the work.
That's Sharon's core message, is hope. Sharon, I could not have wrapped this all up any more beautiful to honor all of our panel speakers and all of you guys for sharing the past 2 hours with us. I am so grateful, so blessed by the faculty, and love you all so much. Thank you so very much for having the time. I'm going to follow up with an email to link you to the recording and additional resources that you can share. That you can also make comments in that space as well. So Thanks again, you guys. And as always, take care and care well. Mwah! Love you all. Wow, so amazing.
Bye, Mary.
Bye, guys. Bye. It's like I'm the host, so I can't leave first. I have to, let everybody walk everybody out to the door. Thank you so much for coming. Take care. Put a coat on. It's chilly out there. See you later. Loved having you. Mwah. I wish I could give you all a big giant hug. That would be really awesome. Thank you so very much, everybody, for coming. Couldn't have had a better 2-hour block. This was brilliant. Better than I imagined. Take care. Drive safely. Bye. There you go. Oops, you forgot your hat. Here you go. Bye. Take it easy. Did you just bite your lip? Oh, okay. See you later. Bye, Elizabeth. Bye, Cassie. Bye, Cheryl. Bye. Thank you for joining. There you go. Take it easy. Safe travels. Loved having you. Okie dokie, bye. Okay, you can all unmute.
This was great.
Oh my gosh, it turned out so good, you guys.
Oh, I'm going to stop the recording.